is pathophysiology in pharmaceutical management, and we will be using Emma's case as an example. So Emma is a 70-year-old female who presents with bradykinesia, rigidity, tremors, and postural instability, and has been diagnosed with Parkinson's disease. So what is Parkinson's disease? Well, Parkinson's, or PD, is a neurodegenerative disorder that affects dopaminergic neurons in the brain. This progressive degeneration of dopamine-producing neurons commonly results in altered motor movements, and some of these include tremors, rigidity, bradykinesia, postural instability, and some others. So to understand the pathophysiology of PD, we must look into the brain, focusing on the basal ganglia. This is a group of nuclei structures mostly responsible for motor control and is located deep beneath the cerebral cortex in the center of the brain, and it surrounds the thalamus. So looking at a vertical cross-section of the brain, as you can see, the basal ganglia is made up of the striatum, which include the caudate nucleus and the putamen, the globus pallidus, both internal and external, the substantia nigra, and the subthalamic nucleus. Now, these structures closely communicate with each other, as well as the cortex and the thalamus. Now, normally when we initiate a voluntary movement, we have indirect and direct pathways in the basal ganglia. The direct pathway is an excitatory pathway that facilitates movement and therefore helps increase or initiate motor activity, while the indirect pathway is inhibitory to help decrease or stop that motor activity. Now, these pathways work together by action potential stimulation that originate in the cortex and subsequently release neurotransmitters such as GABA, glutamate, and dopamine across the striatum, pallidus, subthalamic nucleus, and substantia nigra. The substantia nigra is what we want to focus on. So this is part of the basal ganglia that can be split into two sections, the pars compacta and the pars reticulata. Of these two sections, we'll be looking at the pars compacta. So this area is where the majority of dopaminergic neurons are located. Now, dopamine has a really important role in both the inhibition and excitation pathways because it binds to the D1 and D2 receptors in the striatum, and depending on which receptor it binds to will determine whether the excitatory pathway is stimulated or the inhibitory pathway is inhibited. So when dopamine binds to the D1 receptor, it will stimulate the direct pathway, which is excitatory one, and when dopamine binds to the D2 receptor, it will inhibit the indirect pathway, and therefore overall causing a smooth, powerful, enhanced motor movements. Another important neurotransmitter we have in the striatum are cholinergic neurons, and these release acetylcholine, which provide balance from the dopamine by imposing it. And normally dopamine and acetylcholine will operate in a manner that balances each other out, causing that smooth, controlled movement. So in PD, there is a degeneration of dopaminergic neurons in the substantia nigra pars compacta, and without dopamine to bind to the D1 or D2 receptors, there is less stimulatory input, and thus the direct pathway is less active and the indirect pathway is more active. And this will overall have a significant reduction in the input going to the muscles. And this is what leads to that bradykinesia, the stiffness, the postural instability, and the shuffling gait. Additionally, when there's little or no dopamine, the balance between dopamine and acetylcholine is disrupted, and this is what causes the tremors and the rigidity. So let's talk about the pharmaceutical treatment of PD. So because this is a neurodegenerative disease, it can't be cured, but we can manage the symptoms. So the most common drug used as a first line measure is L-DOPA or levodopa. It's classed as a dopaminergic agent that is a precursor to dopamine. And this typically is an oral tablet taken and then metabolized in the liver, then absorbed in the GI tract, and then enters the peripheral circulation. The way L-DOPA works is by first entering circulation, then crossing the blood-brain barrier, and then being converted into dopamine by dopa decarboxylase, or DDC. So it can be used, and so this restores some of that normal function we mentioned earlier. So the issue with L-DOPA is that there are enzymes in our peripheral circulation, like dopa decarboxylase or DDC, that try to convert this into dopamine. But we don't actually want this because we're trying to get the L-DOPA to first cross the blood-brain barrier, and dopamine can't cross the blood-brain barrier. So a DDC inhibitor like carbidopa needs to be administered alongside L-DOPA to actually increase the bioavailability. And now there are also other enzymes as well, such as catechol O-methyltransferase and monoamine oxidase B, that reduce the effectiveness of L-DOPA as well. So the relevant inhibitors may need to be given to increase that bioavailability. The indication for levodopa would be having PD, but there isn't a specific test to determine if you have PD. And diagnosis is based on the presence of those common motor symptoms, as we mentioned earlier, regardless of the Regardless of the diagnosis, the use of levodopa is used to manage those symptoms. So Emma, as you can recall, is diagnosed with PD due to those hallmark symptoms. Now, it's likely she will be started on levodopa and carbidopa or other related inhibitors because she suffers from those tremors, the rigidity, postural instability, and bradykinesia. So some of the considerations for patients like Emma who may be on this medication are to ensure that this medication is given on time. This is because symptoms can start to worsen quite quickly. Monitor for any side effects and the effectiveness of the medication. And some of the common adverse effects include nausea, dizziness, postural hypotension, headache, and somnolence. And so it's essential for us nurses to provide that patient education, explaining some key points, such as it may take 2 to 6 weeks to reduce symptoms and that high protein diets impact on absorption. And also to never stop abruptly, as it's associated with increased risk of neuroleptic malignant syndrome. Typically, these adverse effects occur due to the dosage being too high, and so that excessive dopamine can cause dyskinesia or chorea because of the stimulation of that excitatory pathway we spoke about earlier.